I got asked last week to help out with this sim, and Andrea was like, you can do whatever you want. I was like, sick. So we're gonna do some ultrasound cases. Instead of like actual sims. Is that cool? Yeah. All right, let's start off with like a chill one, like a easy one, kind of fun one. This is in the abdomen, suprapubic area. What do we think? Okay, could be in the bladder, yes. The walls are kind of thick for it to be the bladder, though.
Could be the uterus. And it could be
the Eucharist.
The Eucharist.
The Eucharist. So this is the fundus.
Oh, that's the baby. Twins.
Twinsies. We got twinsies. That's kind of fun, right? Just to know what it looks like. Twin. Yes, ma'am.
Never.
No, you.
Well, I was looking at the superior one. Looks like there's significantly more baby, and then that one looks more empty. But I think as you scan, you see a little bit more.
Yep.
My question was,
Yes. What is the earliest definitive sign of an intrauterine pregnancy?
yolk sac? Fetal pole.
Yes. No. Respectfully. So the yolk sac is the first definitive sign. It is more easily visible than the actual embryo. A gestational sac, and that's actually important, a gestational sac by itself means there was a pregnancy or there is a pregnancy somewhere. But until we see the yolk sac, we can't say that it's intrauterine. You can have something called a pseudo-gestational sac, where you can have an ectopic, and due to the hormonal milieu, you'll also have a gestational sac. It'll just be an empty gestational sac, but you'll have it.
So yolk sac is the
Yolk sac is the first definitive sign. Yeah, other ones are suggestive. And then, the yolk sac, you'll see that, and then after that, you'll start seeing that fetus, you'll start seeing the heartbeat, all that stuff. Can I tell if these are viable pregnancies right now? Maybe, I don't know, like the first thing is to look at the heartbeat, and you can see it pretty easily. Wait for it, right there. Yeah. So I can see that, and then there's a little flutter right there, little flutter. But we really need to check the heartbeats, actually. Try to avoid using the pulse wave Doppler. That's the one that makes the noise and the nice spiky waveforms. It's theoretically more energy to the fetus. There's never been documented harm from this, but it's one of those things that we just try to do the least amount of energy in general that we can do. And there's probably like a cumulative thing, right? Like if you do it, it's probably fine, right? But like what if the baby gets like 1,000? Potentially could cause issues because it is energy. It is energy. I mean, we would never do this, but they've done studies where they just hold a probe on stuff for 5 minutes, and it causes harm because it's energy, right? That's without moving and just stuck on very friable rat tissue, actually, rat lungs specifically. We don't do that, and it's never been documented really to be any issue in humans, but just keep that in mind, especially pulse wave Doppler. Use your M mode for this. M mode and B mode are the exact same data, just interpreted a little bit differently. So it's no more energy. Yes, ma'am.
I hadn't used M mode in a while, and I did it yesterday on fetal heart rate, and I got it, I froze it, and I could not figure out how to measure, so I counted just physically.
Yeah.
I was on the mind ray, and I haven't.
We can go over it. Yeah. It's doable. There's usually a measure button, and typically it's very readily accessible if you're in the OB setting. Which is an important reason to use the appropriate mode, but it should be, I'm fairly certain it's present in the abdominal setting as well. Okay.
Because I had measure, and then it was all these fetal measurements, but I never saw it, but I might have missed it. I don't know. I was
no worries.
Quite befuddled.
Hey, we were supposed to be on shift yesterday, and you bailed on me, so I could have taught you yesterday.
Who, me? Oh,
yeah.
Really?
I had you, I looked at the schedule, and I haven't worked with Macy in a while, and then you weren't there. And I was sad.
Oh, me and Natalie switched.
Yeah. And then Natalie didn't work with me either.
Our shifts are weird because I was an hour off.
I think it's by design.
Between you and Whit. And so I was like, I don't know who to work with.
I think technically it was me.
Technically it
was me. So yeah, so it's on purpose. It's because that gives you time to start seeing patients. That gives you time to acclimate. It's made on purpose that there's overlap with the attendings. So we're working on like kind of figuring that out, and it might change as we get more residents. When I was a resident, it was similar setup as here. It was like a hybrid community academic shop, and that group was owned by another. It was similar. Like the ER docs are paid by EMA, and it was similar with that over there. And what they did is they basically had the resident do every other attending. Is how we did it there. We have 4 sometimes at the same time, so that doesn't work for us. So we're trying to figure it out. But for the most part, you are kind of like assigned to an attending, and you come an hour earlier than the attending you're assigned to, but you can basically staff with whomever you want, especially in that first hour, like staff with whoever's there. And then in an hour later when that attending comes, the goal is for you to like staff it with them.
So she would have showed up staffed with WIT, and then you would show up and then you would just kind of
like
patients with WIT and pick up with.
Yeah.
I think it's weird these months too, because our staffing besides hours are different depending on if we have 7P coverage, because we're working 7 shifts. So sometimes we're on a 12 to 4, other times on a 1, 3, 4.
Yeah.
Because it's so inconsistent.
Yeah.
Coming months, that's why I don't think we're lining up as well.
Yeah.
It should get better.
But yeah.
No, I didn't know about the hour like then you pick up with.
Yeah. Obviously, like, you want, one of the things that we're working on as a residency is to try and make sure that you guys we definitely want you to have experience with our non-core faculty, but we definitely everybody's invested in you guys doing well, right? But the academic core faculty, we're very heavily invested in you guys doing well, and it's hard for us to give you feedback if we don't work with you. So, yeah. So all that to say, like, staff with whomever, but it's the one that comes an hour after you is the one, typically. Cool.
Sorry.
No, that's okay. That's all right. Yeah, no, it's not like I'm not the type of person to like steal you. Like you're learning from WIT. It's great.
Stolen me would have been a dramatic.
Little eye roll.
I just swept you away. I'd come in a horse. Okay. All right. What are we looking at here? All right. What, based off of this, what is the patient's volume status? Trick question. You can't tell the volume status based off the IVC.
Well, it tells you it's suggestive.
It's not collapsing. Okay, but does that tell you the volume status?
It's suggestive of how they'll respond
How much they'll
to
tolerate.
Okay.
Well, like if they'll respond, right? So if it's plethoric, right, giving them a liter of fluids likely not going to make a difference. If it's dry, it suggests that if you give them fluids,
Dry, you meaning flat and collapsed.
if it's flat collapse, that they would respond to.
Tolerance.
Raisin versus grape.
Yes. Are they a raisin or a grape? That's correct. Understand that what we need to do as physicians, as providers, is be able to identify this and apply it to what's going on with the patient. The data this is giving you is data on the central venous pressure. That's all it does. This estimates the central venous pressure. Pretty good, actually. And cardiology uses this frequently to estimate right-sided heart pressures, the right atrial pressure, which in turn can help you figure out pulmonary pressure. So it's an important thing to know. But you can have a low CVP and be volume overloaded. You can have a high CVP and be severely dehydrated. Can you think about a case where you'd have a very plump IVC but be overall volume down?
Yeah, or portal.
Tamponade. I'm trying to think about SCAPE. SCAPE is from it's not a primary pulmonary thing. It's the heart can't push through it, right? So it would still be kind of like a heart failure situation, right? No, I'm trying to think through it. I'm like here trying to think with you through it. So if that's the
Backload of
right.
pressures.
Okay, so physiologically it's kind of similar to heart failure then. So you would have a plump IVC, and you won't necessarily be volume overloaded. You might be euvolemic or volume low. So yes, agreed. I just had to get through it. I agree. Tamponade, absolutely. Can be very volume down and have tamponade. What's some other causes? Cor pulmonale, acute and chronic. Yeah. Yes. Which is cor pulmonale, basically. It's right heart enlargement. Natalie, you're up. What's another cause? I got one more I'm thinking about. Already said PE. We already talked about that. She talked about tamponade already. Another cause of an obstructive type picture from the chest. There's one more. It's trauma often. Yes, attention pneumothorax. That's the other one that can cause it. So you might look at a plump IVC. This one's right in the middle, by the way. It's neither high nor low. But you might look at a plump IVC and just think, oh, they're just volume overloaded. Let's give them Lasix, when in fact, they actually have tamponade, right? Dialysis patients, what I'm thinking about. So important to identify this in context. Where do you measure, by the way, if you're actually measuring? And the measuring really only matters if you need to estimate the right atrial pressures, honestly. Like most of the time, I just eyeball this. Is it collapsing a lot or a little bit? Is it fat or not? I'm very subjective about this. You guys know if you happen to need to measure it, where?
I believe it's 2 centimeters from the junction.
Yes.
Like 2 centimeters from there.
So 3 centimeters from the right atrial junction, or 2 centimeters from where the hepatic vein goes in. You just have to do it the same in your measurements. So I have a question for you. Should you use M mode to measure the IVC? Yes. Tell her. Exactly. So M mode is brilliant. Ravenclaw?
I don't know.
I'm just trying. Who gets the points? Which house gets the points?
Oh, sure.
I feel like what house would you? Gryffindor? No, Slytherin. Come on, dude. There's no way she's Slytherin. Well, I was thinking like intellectual. Like I feel like the Ravenclaws are like intense and they're very intelligent. You know?
I feel
And analytical and.
Then like half the residency would be like a Ravenclaw.
Great. I'm a Hufflepuff, obviously. Gryffindor. All right, so just to recap what Anna's saying, the M mode stays here, yes?
I've taken the quiz.
I forgive you. All right, good? M mode. We're only measuring one line here. We're measuring 2 different locations. That's why we don't use it. Like, not to brag or anything, but like I can move my IVC like 4 to 5 centimeters. Yeah, it's kind of a big deal. It's fine. It's whatever. So you'll be measuring here, and then the next measurement will be the right atrium. 2 completely different measurements. So do not use the M mode. You'll see it. You'll see other people give ultrasound lectures. You'll see it in textbooks. They'll show pictures of M mode. Do not use M mode to measure the IVC. It's silly. Cool? Sick. So this patient needs an ultrasound guided IV.
Look at that nerve.
This would be a tricky one, right? Yeah. So you said look at this nerve, this guy, yeah?
Yeah.
Good nerve up there. Which one of these is the artery, which one's the vein? I can, but I didn't.
So it's the pulse. You want to look at the pulsatile one.
Great.
It looks like the guy on the left is more pulsatile.
That one? This one?
That boy.
Yeah, there's no way to know. That's the end result. There's no way to know. Natalie, you said, is it pulsatile, right? Or was that you, Anna?
No, she said that.
Dr. Kachi, hello. I want you to know that I was in the half of that meeting.
That's cool. I get it.
I was there as long as I could. Enjoyed the discussion. Okay, so you can only tell if it's pulsatile, right? You can throw color flow on it to help. You can use pulse wave Doppler, but easily as pulsatile. Is pulsatile, and you do that by holding pressure and waiting. And the one that starts to pulsate is the artery. Don't look at compressibility, because in a hypotensive patient, the artery will be compressible as well. So I see people do like, pop, they'll do like a doop, and everything will compress, right? Hold pressure, and the pulsatile one is the one. Obviously, we want to avoid going through this. Let's just say this is the vein. Let's say, I don't know, that's the vein. Which that one's honestly probably the artery. That one has a little bit more of a thicker wall in my kind of estimation. And usually the arteries don't get bigger and smaller. That's usually veins that kind of are a little more tortuous. But let's say that this one is the vein. Let's just say, what would be the best approach to get that vein? How would you get to it? It's hard, right? You don't want to go through that median nerve, right?
Later in the clip, it kind of way, and I think
Mm-hmm.
go from
So you're thinking let's see, maybe here?
yeah, and come from a slightly lateral.
No, yeah, agreed. Now I'm fanning through this, and we only have, this is probably on the skin, a centimeter of space. So we have a very small window. So you'd basically have to plan it. You'd basically say, I'm going to cannulate at a specific time. So here, let's say, right? Yeah, right around, actually, no, I don't like that. We'll say here, this is where you want to cannulate, right there. What you would do is you would actually plan and actually stick it more, the needle in the skin more distally, where you're basically right above, here. So you'd start cannulating here, knowing that as you progress down, you're going to get it right in that spot, and then adjusting your angle. It's tricky. I've told the twos quite a bit this. Yeah, that's correct grammatically, right? 2 as well. Try to do as many ultrasound guided IVs, even if it's annoying, even if you're busy, even if you feel like you're not good at them. Because what is the worst thing that can happen with an ultrasound guided IV if you do it wrong? It hurts. They squirt a little bit. If you hit a nerve on accident, they'll just go ow, and you'll be like, I'm sorry, and that's it, right? What happens if you cannulate the carotid artery? But what's the worst outcome that can happen with IV versus a central line that you mess up? Nothing. Death. Right? This central line, honestly, a good, easy, a central line, someone that's not severely hypotensive, piece of cake. It's so easy, right? And I know that I know you guys have done so. I know you guys have. There's so much line guide IVs that are very frustrating. They're very hard, right? Super small target. It's hard to see the needle, all that stuff. So if you get really good at the harder thing, the easy thing is going to be a piece of cake, and it's very unlikely that you cause any harm doing a more invasive procedure like a central line or like an R line, for instance. So practice with those ultrasound guided IVs. Do as many of them as you can. My expectation is that when you guys leave residency, wherever you go, that you will be the ultrasound guided procedure experts. Of course, IVs, but the technique is the same. Arthrocentesis, it's the same for nerve blocks. It's the same for ultrasound guided pericardiocentesis. For everything that you can stick a needle in somebody, you can do it under ultrasound guidance, and it almost invariably will increase your accuracy. Cool beans? Sick. All right. And I'm giving this out of context because I want you guys to think about it. No, maybe we've had patients like this, but I don't think this was, wait, did I say with this group or the last group, how I'm the collector from Marvel? I keep all of my ultrasound clips, all my good ones, since I was an intern. So I have a encrypted hard drive that it's backed up as well because I don't want to lose it. But I have all of my good ultrasounds over the past 11 years, basically. And so I have a bunch, but to answer your question, Chris, I have about 100 ultrasound clips that I haven't shown anybody yet. And this is that set. So these ultrasounds are 4 years old. Oh, okay. And I haven't shown anybody yet. Okay. Yeah, world premiere. All right, so I'll start off if you guys can pause for a second. What part of the body is this, either of you?
Liver, and it looks like
Mhm.
it's the aorta because it's lower than where the IVC.
Yes. Everybody okay with that? All right, so the IVC goes this direction. Aorta is going behind the heart. This is where the heart would be. And then this is a dissection. This is actually a transhepatic view of the aorta, which is important because sometimes our patients are a little on the fluffy side or they have a bunch of gas and we can't see it from the AP direction. If we go liver and we angle it away, depending on how the patient is, we can see through the liver. There's no bowel gas, so we can get to the aorta. The transhepatic view of an aorta dissection. Sick.
We had, I think, a coding patient that we put a line into, and the wire was still in, and then you were looking at the abdomen, and it looked like a dissection. It was the
Wire. Guide wire.
It was the guide wire.
Yeah, I do that a couple times. I actually had one the other day. It was a very difficult central line that I ended up helping somebody else with, and we ended up doing an ultrasound guided subclavian, and the vein was so small, and I had this much space because it was a tiny person. Because when you do an ultrasound guided subclavian, you actually want to come inferior and lateral, like a little bit out this way, because you want to actually like track it, right? And remember, it's like the axillary vein, and then it turns into the subclavian when it gets underneath the clavicle. But I only had like this much space to work with, so I couldn't get the needle. I couldn't see the needle tip in the vein. I aspirated what looked like venous blood. It was not pulsatile, but I wasn't 100% sure that my needle tip was in the vein, so I did that same thing. So you put the guide wire down, and then you have another operator with a cardiac transducer look in the subxiphoid view to see if you see it in the IVC or in the right heart. And if you see the guide wire there, you're in a vein. You're in the appropriate vein, you're in the SVC. The only downside is that if you wiggle the endocardium, you can get arrhythmias. So if you do that and you happen to see VTAC, just pull the guide wire back. VTAC will go away. Cool? All right.
Do you actually cannulate for those? Are you cannulating the axillary vein, or are you actually cannulating the vein? I mean, ultimately.
Technically, it's an axillary vein cannulation, technically. But it's all the same, right? I mean, the distance between, it's...
Centimeters.
Exactly. So it's technically an axillary vein, but it's very much semantics. Doesn't matter. You're cannulating a central vein. That the goal is for the tip to be in the SVC. Cool.
I tried to do one, and I was trying to use the ultrasound, and I could see the subclavian. You could see it, and then I was like, "There's no way I can hit that with the."
You can.
I mean, I guess on this patient.
Oh, fair. No, that's very fair. And we can go over the technique. And this isn't in general. If you need help with something and it's not my patient and I'm on shift, I'll help with any procedures. I love procedures, but especially ultrasound. Come grab me. It's not an inconvenience. I would actually like it because the way I think about it, I like teaching, and then the way I think about it is that if more people know how to do it, then other people can teach other people. So I'm very happy to teach you guys whatever with regards to anything, especially ultrasound stuff, even if it's not my patient. All right, what are we seeing here? They're the same disease, different patients, but same problem. Yeah. So this one right here, cyst. Let's talk about this one first. What's weird about this one?
It looks like it's kind of in the...
It's in the meat of it, right? Yeah. Normally when we see cysts, they're very peripheral, right? So that's something to think about. There's also a calcification right there, which we don't really worry too much about calcifications on the capsule per se. If there's calcifications on the inside, it does increase the likelihood that the patient might have actual cancer, because that's really what we care about, right? Do you know of any, how do you tell if something's a renal cell versus just a simple cyst?
There's a green system. There's
Yes.
There's 5
Yes.
categories.
Yeah.
To do essentially
Do you know about this? Called the Bosniak classification with a K, Bosniak. And there's 5, but there's actually 6 because there's 2 different 2s. There's a 2F and a 2, I think there's a 2 and a 2F. From 2 and below, so Bosniak 1 and a 2, needs 0 follow-up, and it has to do with the size, which I think you were going to mention, and only 1 internal septation. When you have 2 or greater, it's bigger than, I want to say it's 3 centimeters. I don't know off the top of my head. If it has internal echoes, longitudinal echoes, then those actually need follow-up. And if you can look up this classification, I actually have to look it up fairly frequently if I have a cyst that doesn't look like this. But if you have basically 2F and above, they require different levels of urgency of follow-up. All right. Now, look at this guy. This is like the biggest renal cyst I have like in my collection. It's a massive renal cyst. How do I know it's not free fluid? Okay, of course. Yes, it's in the kidney. Well, yes. It's got like a capsule and it's circumscribed. It's a circle. Free fluid in the belly is usually pointy because it has to fit in the little recesses, it has to fit in between the bowel. So that's why I know that it is not free fluid. It's pretty big though. Like this is a quite big thing. Is it time already?
5 minutes. Oh, we're done. We just got it.
Oh, okay. You can come tail end of this. Yeah, I don't mind. What do you guys see here? Yes. It needs to get a job. It's lazy, right? Everybody cool with that? Now, what if, let's say this is a code. Where do you think you're going? Just kidding. Go ahead. Let's say you're in a coding situation, and somebody says, "I feel a pulse." What do you say? You call shenanigans, and they have to leave the room for 5 minutes, and then they can come back. The pulse is often highly inaccurate for detecting the presence or absence of a pulse. Okay, there's studies that actually back this up. If you see a bounding pulse, they got a bounding pulse, but besides that, it's not great. There's a great study, it's an older study where they actually took a bunch of medics, and there's no way a medic is like has better fingers than a physician. Like they're the same people, right? They put them up to the cath lab. They had the patient covered. Basically, all they had was the wrist, and they had the patient on or off bypass. Pretty good gold standard, right? Their heart's either connected to their body or not. And it's crazy, the numbers. I have it in my cardiac arrest lecture, but it was like 25% of the time they were wrong. It's insane. And the average time it took to make those wrong decisions was like 25 seconds. Yeah. So that's why I still the most important thing of cardiac arrest in ultrasound in cardiac arrest is to identify reversible causes. That's the most important thing. And in fact, there's a study that was done that found that when ultrasound was performed and a pericardiocentesis was performed, those patients had a 15% survival rate. Do you guys know what the normal survival rate is for arrest?
It's like 6%, right?
Yeah, I've read that it's about 4% in all comers. So you go from like a 4% average survival rate to a 15% average survival rate by identifying a pericardial effusion and doing something about it. So like identifying reversible causes is quite important, but I still use this in pulse checks, right? Because of this, like, do I need to wait 10 seconds to resume compressions? Why not? How do I know this is not severe bradycardia, let's say? We can see that this is the heart rate. This is like, you'll see the electrical activity of like boom, boom, boom. So we'll see this. So I'm seeing that. I don't see any obvious signs of VFib. I don't see VTAC. We don't need to wait 10 seconds for this. Very important consideration is how to do it. And I have I have a whole cardiac arrest lecture where I talk about this more in depth, but basically don't let you looking for the heart delay chest compressions. That's the only thing that's been shown in arrest to invariably help outcomes. That's chest compressions. Epi doesn't help, shocking maybe. Nothing that we do helps except for chest compressions, right? There are 2 studies, and they're observational studies, kind of cool. They had cameras, basically, so they were able to just directly observe, without them really knowing per se, and found that when ultrasound was used in pulse checks, it prolonged pulse checks. It's kind of disappointing. I have a question. Have any of you ever seen an ultrasound scan anybody by itself?
No.
Get out. Caleb.
Ultrasound scans.
It depends, don't kill
Yeah.
people. Ultrasounds don't scan people. People scan people.
Yes, exactly. So who's doing it wrong? Who's prolonging the pulse check? Is it the ultrasound?
No.
It's people doing pulse checks wrong, right? Whenever I have an arrest, what I like to do is persons keep track of time. I want them to count down from 10. When they get to 2, probe off. Doesn't matter if I almost have something or I think I see something. Probe off, rag in my hand. I'm wiping off the gel. So I don't want to be the cause of a delay. And honestly, if you can't see a view at all within 5 or 6 seconds, the chance of you actually eventually getting a decent view is pretty low. Actually, they've actually done studies on that. So don't let it prolong your pulse checks, please. Now, let's look at one more. What if somebody says, I feel a pulse with this ejection fraction? Macy, if you had this EF, I don't know if you would be perfusing. I don't know if you would have compensated, your body would have compensated enough for this to be perfusing. Does anybody know how to tell if a blood pressure is perfusing? And perfusing, I mean brain and coronary arteries. It's a number. It's a diastolic of 40. So that's your goal. So how can you tell if this is a perfusing rhythm?
Well, I mean, do they have a pulse? Would be one thing. Like, do they have a blood pressure? I guess would be the.
Okay.
Would be like.
What would be the best way to get that blood pressure? Instantly. Heart line. So this will get a lot easier when we get our next class. But the best case scenario for an arrest is you have like 3 or 4 physicians in the room. One's doing airway, one's running code, one's doing all the procedures. I love having art lines in all of my peri-arrest and arresting patients because it gives you data like this. Don't forget. What do we see here?
Equal 4-chamber.
Yeah.
LV dysfunction. Zeus D. Really good tap. Shitty.
Pretty good tapsy.
Yeah.
What that?
Something on the valve.
What is that?
Goomba.
It's a booger. It's a valve booger. We had a lot of this. We're at my old school in Kentucky. A lot of IV drug users, and so we would see right-sided endocarditis a lot. The typical picture was we'd have a youngish person, had cold symptoms, had a non-specific X-ray, and the non-specific X-ray, said maybe viral process, maybe not. Had been on a Z-Pack, got maybe a little better during the Z-Pack, and then got worse, and they don't look crummy. And track marks. I do the ultrasound. This is pre-COVID. I do the ultrasound, see little subpleural consolidations all over, and I'd be like, oh, and then I look at the heart, and it would show a goober on the tricuspid valve. That's like the classic presentation. Although I will say that, like, if you look at the data, it is the most common endocarditis is actually aortic endocarditis, which I didn't know, just because it wasn't seen in my population, but it was in a study. And I was like, okay. How do you get endocarditis? Like, valves are pretty smooth. Like, they're like the inside of a urinal. Nothing really sticks to them. So, like, how does something stick to it? Typically, that's what it is. Sometimes you're just going to get it like you have like a little pocket or whatever. That little pocket that bacteria is able to seed, but it is associated with any kind of surgery in the heart, any kind of valve replacement. Those patients are at higher risk for endocarditis. And it's just something to think about with regards to history to bump it up on your differential if you need to, because the ultrasound is quite, the transthoracic ultrasound is quite specific, but not sensitive to rule it out. So if you don't see it, but the patient has a clinical picture, blood cultures admit for a TE, basically. Cool? Yep. It's not a great view, but the patient was in a bit of distress because they got shot in the chest. Yeah, so why is this a clot and not a huge pericardial fat pad? It like wiggles apart from it. It's like wavy and it's not fully attached. A fat pad, the entire kind of like inferior margin, like this whole section right here, is just completely attached. We also see a little bit of hypoechoic fluid above it and a little hypoechoic fluid below it. And we also have a history, and we see the patient. The patient was young. They weren't, 500 pounds and 80, right? They were like normal sized and fairly young. There's also a decent amount of gang violence that we would get because we were like a level 1 trauma, so we got a lot of these traumas. Let me ask you a question. This patient is a little hypertensive. Do they have tamponade? Correct. They have tamponade irrespective of blood pressure. What is Gryffindor? Okay. 10 points to Gryffindor. So apart from Katie, what is the diagnosis of tamponade?
ultrasound findings can be diagnosed.
Yes, and also irregular, right? So the diagnosis of tamponade is obstruction to filling of the heart, essentially. If you really boil it down, that's what we're looking at. What is the earliest finding of tamponade? Probably. But what happens before the tachycardia? That's clinical manifestation, absolutely. In fact, I'll get through this later, but tachycardia is a very mild, especially tachycardia in general, even mild tachycardia is probably the most common vital sign derangement and presentation, honestly. So yes, 5 points. Well, that's what I'm looking for, but it is a correct answer. Is that okay? Are you Gryffindor as well?
I'll be Hufflepuff.
Great. I'm Hufflepuff. Yes. Okay. So the earliest finding. So you're excluded. The rest of you. What's the earliest finding? Sonographic finding.
Earliest sonographic.
Of tamponade.
Diffusion?
You get 5 points. You're right, because you have to have an effusion for it. Okay, now you're excluded. Okay, the three of you. This is for 15 points, you guys.
Right atrial collapse?
You get 20 points, actually. That's exactly the right answer. It's right atrial diastolic collapse is the earliest finding. The more common finding that we talk about is right ventricular diastolic collapse. Now, some people might say, that's because the right atrium is the lowest pressure system. That's why. Now, there's a couple like parameters with the right atrium. Like for instance, you are much more specific if you have right atrial collapse over a certain period of time relative to the whole cardiac cycle. It's a little complex, which is why we usually look at the right ventricular diastolic collapse, because it's just easier to evaluate. You have to actually do this weird thing called the RA inversion index, and it has to be greater than a third of the whole cardiac cycle. Like it has to be collapsed for greater than a third of the cardiac cycle. You can imagine that's like difficult to calculate, right? Any collapse of the right atrium is only about 80% specific. So that's why really to be the most specific, like you have to have that timing, and it's hard, right? So that's why we looked at right ventricular diastolic collapse. Notice that I said right ventricular diastolic collapse and I said right atrial diastolic collapse. That sometimes throws some people off because usually when people talk about systole and diastole, they're talking only about the ventricles, right? But the way that I remember this is what is tamponade. We talked about it. Tamponade is obstruction to filling. So basically the heart collapses when it's trying to fill, okay? What is diastole in general? Relaxation or filling. Systole is contraction, right? So to help me remember, I just think about it as the chamber. So I think about it as the right atrial chamber's diastole and the right ventricular chamber's diastole. So technically it's collapse of the right atrium during ventricular systole, but that is atrial diastole. So that's why I say it that way. It's easier for me to conceptualize it. Cool? No problem. So diastole, I think about it per chamber. So if you have right atrial diastolic collapse, you're in ventricular systole. Because when you're in ventricular systole, the atrium, that's when it fills. Because it can't, it's not like a channel goes all the way through. It's like the atrium first, then ventricle, they alternate. Cool beans?
That makes sense.
Sweet. You can do IVC too, if I'm ever not 100% sure. Their blood pressure is normal. There may be a little tachycardic. They have a significant effusion, but I'm not seeing a whole lot of collapse of that right ventricle. I'll do the IVC as well. I think that's an important thing. If they have a high CVP, it increases the chance that they have tamponade, an obstructive process. Cool?
Tamponade yesterday.
Yes.
Actually, her patient.
Yeah, so we had a guy come in with a self-inflicted knife wound, and the attendings actually did multiple pericardiocenteses. First one, it didn't seem like the guide wire threaded all the way through.
Where'd they go? Here? Here?
Subxiphoid,
Here.
yeah, and ultrasound guided.
Yeah, but they did the ultrasound up here.
Up there, yeah. So
Trying
it was right.
to visualize the needle down here.
Yeah.
That's
it was
incorrect.
Very strange.
Yeah, but it was like a real high stress situation. I'm just sitting in the corner of the room watching everybody do it. And I'm
There's
just
a lot of passion, a lot of barking. We were just trying to save the kid's life because.
It's funny, we get used to all the ultrasound gurus and working with them, and then
You go to somebody who's like never picks up the ultrasound.
Yeah.
It was just the old attendings, and I was just like, that is
Yeah.
not
They did
ever
it that
gonna
way in
work.
the other guy with the gunshot wound recently too at Inland.
Yeah, and so we were concerned that
I was like,
the
wait.
line was starting to clot at one point, and then I'm like, what the hell are we supposed to do? Like, aside from like, try to do it again, but even though, like, anyway, if you find something, if they're tamponading, you have a huge clot in there, you try to extract as much fluid as you can. And just like yesterday, they weren't comfortable with taking him to the OR, they wanted to transfer him. Like, what do you do to try to, you know, obviously.
Be a good patient advocate.
What?
Be a good patient advocate.
Yeah, and, you know, get him out of there, get, you know, be a MTP activated.
He was never hypotensive that I saw. He was hypoxic.
He was hypotensive in the beginning, but you're right, he was hypoxic, and it was a strange picture because even when we had the ultrasound on there and we're actively, you know, drawing back blood so that the effusion, we saw it disappear, right? And then it would respill, so we think he lacerated a great vessel. But when it had disappeared, he was still hypoxic. We had already placed a chest tube. It was a weird mixed picture. But then when we extracted some of the fluid, his hypoxia would partially resolve, but not fully. It was a very.
Sorry. Couple things. You're bringing up a very good point about the blood pressure. Are there any parameters with regards to the blood pressure to diagnose tamponade? There isn't. Most patients, if you look at the cardiology literature, that's the gold standard, right? They do their own echo. They have an actual catheterization in with actually directly measuring the pressures of the heart. Most patients in tamponade are normotensive or hypertensive. Why? Yeah. What's the first thing your body does when it senses something's wrong? Adrenaline, right? Catecholamines, which clamps down, increases the heart rate, tries to increase that cardiac output. That says cardiac output, right, is heart rate times stroke volume. So it tries to fix those. It can't increase the stroke volume per se based off of volume, so it's going to increase the heart rate and it's going to clamp down to try and move more of that blood where it needs to go. And that's important because you should not wait until a patient's hypotensive before you do something about that tamponade. And I'm not saying you have to do a pericardiocentesis on someone that looks stable and seems like they might have tamponade. That's what I'm saying. What I'm saying is that patient has tamponade and they need very expedited care. I love doing any procedure at the bedside except for lumbar punctures. I don't like lumbar punctures, but every other procedure I really like to do. But it is better for patients if they do it in a controlled environment by someone whose job it is to do pericardiocentesis, a cardiologist, right? My kind of flow, and I have a specific example of when I was in Kentucky, which was I had a patient that had very obvious sonographic tamponade. We had fellows, cardiology fellows, and they're great. But we would have, sometimes we'd have a first-year cardiology fellow that was unfamiliar with my knowledge of the literature and my ability to scan people, right? They didn't know who I was. And also they were just a resident like a month ago, right? And I had them tell me that the patient wasn't in tamponade, wasn't going to wake up as an attending, basically. And I told his resident, and really I'm not rude. You guys have seen me have interactions with other attendees and other patients. I'm not rude. I just summarize when I talk to you guys about it. But I basically told him, if you don't wake up your attending and take this patient to the cath lab, I'm going to do this. You have 20 minutes. And in 15 minutes, he was up in the cath lab. You have to be a good patient advocate, and you have to push when you know the right answer. You have to know the right answer, by the way. You have to know that you're correct to be that forceful, but be a good patient advocate. Now, with specifically what you were talking about, that is I'm not going to say incorrect, but I'm going to say that is not a traditional way to do ultrasound-guided pericardiocentesis. I have a video on the website. You guys remember when you had that pericardial simulator, tamponade simulator, back there? I recorded some really good videos, and so I'm going to create another kind of tutorial. Maybe we can share it with those people. The worst place most of the time to do a pericardial centesis is the subxiphoid place. It's probably the worst most of the time. The distance is the furthest most of the time. You're invariably going through the diaphragm. So you're poking a hole in the diaphragm, which probably doesn't cause too much harm, and you're also most of the time poking a hole through the liver. It's very far. It's actually hard to see it. Like it's very hard to stick a probe in the subxiphoid area and to be able to put that needle in there. Your angle is going to be like very not great because remember, like you want to be as perpendicular to the beam to get the brightest angle, and to go this sharp, like you're going to be like this. It's going to be very hard to see it. Usually what I do, if I have to do the pericardial, the subcostal, say subxiphoid, cardiologists say subcostal, even though this is the subxiphoid, I don't know why. If I'm going to do the subcostal approach, I almost do it as like a pseudo-blind technique, like a pseudo static guidance. I'll put the probe and put the heart and the fluid that I want right in the center of my ultrasound screen. And then I'll basically put the needle above it and I'll try to go directly in the path of where that probe is heading. I try to visualize the needle tip, but it's often very difficult with the subxiphoid, okay? Now what's awesome is that with ultrasound, you should evaluate the parasternal view for aspiration and the apical view. My favorite is actually the parasternal view. If you can see the heart in the effusion, is there lung between your skin and the effusion? No, and that's the big concern. That's why we don't do them blind up here, because the lung is there, right? And we don't know where the lung is. Some people have hearts that are like this. Some people have hearts that are like just underneath the sternum. We can't tell unless we do the echo, right? So I look in the parasternal window first, and if that is a good enough pocket, I'll go there. The more common way that I'll do it is actually, and it's not because it's better or anything like that, but it's just how it's been the biggest window for me, is the apical view. You don't need to, in fact, if you're doing parasternal, you should use a linear probe. You don't need to see the whole heart. All you need to see is the effusion and the border of the heart. That's all you need to see. You don't need to see what the heart's doing. It gives you much higher resolution. It's like you looking at like a piece of cake. Yes, ma'am.
We went into Rush. I pulled up
a... Okay. So here's the problem, is that standard of care and the right thing are not always the same thing.
Exactly. Sometimes standard lags behind most recent literature.
Yes.
And it takes a while to process it.
And we have discussed how we have some colleagues that are quite good at their job, but they might not understand how to utilize the test the best. And so, and actually, and this is, I'm getting this literature from this data from Centraline literature, and you can extrapolate. If you have somebody that's really good at ultrasound, at landmark-based subclavians, which I'll say I'm pretty good at landmark-based subclavians. I did probably a little over 50-ish when I was in residency. And then I started doing ultrasound guided subclavians when I was a fellow, and I'm like, why did I ever not do this ultrasound guided? Like I felt bad. I felt like I'd stolen candy from someone. I'd done something morally wrong by not using ultrasound for subclavians. So I didn't know how to do it. That study showed that when you have someone that's good at landmark-based studies and you make them use an ultrasound, they are more dangerous. They are more likely to cause harm. So that's the problem, is that you can say something standard of care, but if people don't know how to do it, it actually might be worse for the patient because they don't know how to use this new thing. But that's why Shen and I and Kachi, we really push the ultrasound stuff because it's a superpower. It's an extra step that you can do. All right, so back to what we were saying, linear probe for the parasternal view. And then I usually use the curvilinear because I usually need a little bit more distance because remember the linear probe only goes down about 5 centimeters. So you usually need a little more distance, it's a little further away, but you can go in the apical window as well. I would suggest going with whatever view gives you the biggest pocket and is the closest distance. Cool beans? What happens if you don't have a pericardiocentesis kit at your shop? Central line, art line. Any kind of long catheter. The reason the central line is good is because I think it's a 12 gauge. It's big, right? And so that's why it's nice. And then you were mentioning the whole, aspirate as much of the clot as you can. That, I don't do that. And we had, Andrew and I had a case that is adjacent that we are not going to discuss, Andrew, because I'm going to do an M&M on it. We're going to do an M&M on it. It's a great case. Basically, if someone's bleeding and they clot, they cause like a tamponade of that bleedy thing. They block it. So if somebody looks really sick, I would aspirate, and that's why the central line or the pericarditis kit is so important. Aspirate until their mentation gets better or their blood pressure gets to a blood pressure that you're happy with, and then clamp it. You're not aiming for like MAP of 65. You're aiming for stable-ish. Cool? All right. Any other questions or thoughts on time? I think this is a pretty important thing to like understand well.
Wait, I guess.
Yes.
What happened at the end of your case?
The patient died, actually.
Oh, they did?
I have no idea. I just always say that.
No, because they got transferred out. Reach took them to Loma Linda. But we were concerned that, my attending and I were concerned he was going to come.
Yeah.
Did you guys leave a catheter in the pericardial space or anything?
Well, see, so they got it, right? Like they got it. So, and that's the thing too, is that like, as long as it happened, it happened. Yeah.
One of the things I learned from our cardiologist doing one of these like a couple months ago was, because a lot of times for me, I feel like I don't get this view. It's never as pretty as this. I know there's a pocket there. This patient's in impending tamponade, and then I hit something, and I assume I'm in the pocket, but I have no idea. I don't know if I went through the right ventricle or something else like that, and so I don't want to float a wire or anything to that. I can't confirm this. And he said one of the things that's nice to do is almost like you do a bubble study for echo. You just agitate some saline and you flush, and you make sure that you see the bubble flush around the heart and not in it to try to better confirm your space before you put anything bigger in.
Brilliant. Absolutely correct. Yeah. Yeah. One of the things too is that like you're maybe taught that, yeah, if it's pulsatile, right, like that is you're in the heart. But if you have a heart that's in distress, that fluid is going to move around with the heart and it will be pulsatile. And it's terrifying, right? So that is a brilliant way to do that. Typically what I do if I'm not sure is I actually would aspirate the blood and push it back in. Because blood is a little more echogenic, and so that's usually what I do. You float the guide wire in there, you can see that under ultrasound guidance. I have a tamponade lecture where I kind of talk a little more specifics about it.
Hey Carson, when you went up to that floor code and you were with Ward, right? Mm-hmm. What approach did you
That one, the
Subxiphoid?
guy was like 570 pounds or something. But I did.
That's great. I mean, that is I think the best to do, especially in a fluffy person, because that's like they don't usually like, especially next to the sternum, like that's usually like the least fluffy part of there, and you can like move tissue out of the way. You can't move intestines out of the way.
You know, I think historically, for me, it seems like they've been teaching this subxiphoid process because I think that's because we didn't use ultrasound.
That's where it comes from.
And I think nobody's really kind of advanced it outside of people that are ultrasound based like yourself. But for the rest of the non-ultrasound based faculty, it's still in most of the textbooks they want you to do a pericardiocentesis subxiphoid.
Yeah.
If you that are saying go where the biggest pocket is.
Yeah. I mean, it takes time for like stuff to shift, and like the skills we were talking about earlier, the skills have to like catch up. And in the early phase, like if you are very comfortable with the procedure and you add ultrasound, like potentially it could actually cause harm if you're not careful. So yeah, and we just got to catch up. It's a good idea always to review what would you do if you didn't have something, right? Like I know some of you when we intubate, you're like, oh, I'm gonna try DL. Just because it seems like an easy one, it's a good one to practice on. Do the same thing with ultrasound. Like really think about what would I do if I didn't have the ultrasound. So go through exactly how to do a pericardiocentesis blind. Subxiphoid, you aim for the left shoulder, slowly bringing it back until you get some fluid back. Think about it. I'm not saying do it, but think about it. Same thing with subclavians. When you're doing ultrasound guided subclavians, also know what to do, like understand the technique for a blind one. There might be some times where you have a crashing patient, that's the only access you have, and you can't see anything on the ultrasound, you gotta try blind.
I would really advocate that for the bougie too.
For intubating, yeah.
Don't try reaching for the bougie for the first time. You actually need a bougie because it doesn't move as easy as it looks. Yeah. Use it on routine intubations. It needs a little bit of tactility to get it to move and thread it where you want.
Yeah, exactly. You want to practice it on a stable patient. Yeah.
What would you say if you're about to
drop this and you're using parasternal and you have an attending who's always done subxiphoid and they're like, no, do subxiphoid, what would you
That's
say
tough.
in like one sentence to try to get them to let you do it? Because I feel like I can see the trauma surgeon at Inland telling me no, essentially, like, no, do subxiphoid, and I'm
All
like,
of them are old
I can
school.
see a pocket, I'm not gonna hit lung. Like, what would you say?
It's a case by case, Andrew, and it's frustrating. Ultimately, I would defer to your attending, ultimately, because it is their medical license that you're practicing under, and you might see a pocket do great, but what if that's the situation, you're fighting them, you're going against what they say, and then you cause a pneumothorax, which might have happened anyways, right? So in those situations, like, I would advocate for the patient and yourself, but ultimately it's the attending's thing. And sometimes we do things that you might not agree with, and you have to do it anyways. And what I do when I was a resident is I internalized it as I understand this, but I'm not going to do this. And that's why you work with so many different attendings, is to learn differences. But what I would probably say is I'd be like, hey, I have I have some experience with this. I can show you that the pocket's really good. I think that the chance is like pretty low. Do you mind if I just try it here quickly? They'll probably say no, but that's what I would try. Diagnosis. Okay. Great. Everybody see that? It's layering. Little washing machine sign. Cool, that's it. That's all I got on this. Does this patient have vision loss? Do they have vision loss? No. They have decreased vision because they're trying to see through a clump of blood, right? But they don't have loss of vision. Does a vitreous detachment have loss of vision? Vitreous detachment. Does it have loss of vision? All vitreous detachments are above the optic nerve. So we have diagnosed a vitreous detachment. Yes. They do not. Good try. You get 5 points. You answered a question. You get 5 points. Yeah, you would be Gryffindor. Yeah, you'd be Gryffindor, right? What's your house?
Sorting people today?
Mm-hmm. Well, who do I give the points to? I got to give it to a house.
What am I
We can't all be Gryffindor.
All right, I'm gonna let it go. It's okay. Carson can do backflips on a mountain bike. Like, I'll let you not. You cannot know about Harry Potter. It's okay. He's not a Slytherin. Come on. He's not pale enough. Like, personality-wise, maybe, but he's not pale enough. Okay, sweet. So the only out of the three, so we have vitreous hemorrhage, vitreous detachment, and retinal detachment. The only one that has overt vision loss is a retinal detachment. Okay? There's other stuff that causes vision loss, but out of those three, like, main things that we diagnose. How many people have vitreous detachments? Is it a small bit, half, or a lot of bit? Vitreous attachments.
Like, of the general population?
Mm-hmm.
People who
Yep. General population. A lot, actually. Especially when you get older. It's actually pretty normal. So you have this thing called schisis senilis. Anybody know what that means? Just anybody speak Latin? Senilis, yes. What about schisis? You guys ever remember like Christian history, the great schisis? So what does schism mean? Yeah. So it's a separation due to old age. That's the schisis senilis. Almost everybody. It's like when you have like a older person with a prostate. They're all big, to varying degrees, right? But they're all big. Almost, if you look at every 80-year-old, I bet you 90% of them are going to have a vitreous detachment. You have the vitreous, you have the retina, okay? With age, this thing shrivels up, it pulls off from the retina. That happens almost invariably. A small percentage of those patients will have an abnormal connection, like an adhesion basically, between the retina and the vitreous. When this comes off, it'll create what's called a retinal tear. It's a small percentage. A small percentage of patients with retinal tears will get serous fluid that goes inside that tear and pushes the retina off. That is the most common cause of retinal detachment. It's called a rhegmatogenous retinal detachment. It's the most common. Cool? So almost everybody that has a non-traumatic retinal detachment also is going to have a vitreous detachment because that's usually how they form. They'll have, follow-up question. What causes flashers and floaters? Why do patients have flashers and floaters when they have a vitreous attachment?
The way the light is bouncing off.
Maybe, but that's not the most like prominent reason why. Ooh, it's you guys again. It's the flashes are mechanical pulling as the vitreous is coming off of the retina. It's like little chunks of it are like kind of pulling and snapping back, like a little elastic band. That mechanical thing causes the flashers, the little lights. And then floaters are the bits of protein in the serous fluid. Those are the floaters. So that's what causes flashers and floaters. Classically, a retinal attachment is going to be like a curtain. Cool? I know other things besides ultrasound. Well, you guys are the first group. So does that mean we're done?
We're done. We have completed.
Can I do one more? I really wanted to show you guys this one.
This is short.
Yeah. So the same patient. This is the unaffected side. This is the affected side. I am posterior, just about at the scapular spine area. What is the pathology? No. A what? What did you say? Effusion.
Right there.
Do you guys know how to drain this under ultrasound guidance? It's pretty sweet.
What about above that too?
That or that?
That.
Yeah, that could be an effusion too, but I think that that's probably it could be artifact. This whole thing could be effusion maybe. There's a chance that could be something called anisotropy, which is when you hit a tendon basically off perpendicular, it will look hypoechoic. It could be that, but that whole thing could be the effusion. The last thing, Rob, may I use your back? Can you pivot with your back towards our residents if you don't mind? So this is the technique. I have the probe right here. So the scapular spine is here. This is the humerus right here. I follow that until I identify the effusion. I have the probe basically right here. And I go basically, as soon as I identify the biggest pocket, I basically go straight down right in that area. So I don't usually do it in the long axis. Most procedures I like in the long axis, but the space is usually kind of small and it's hard to get around the head of the humerus. So I just go out of plane and it's almost like it's almost like a pseudo static dynamic approach basically. Like static ultrasound guidance is you put the probe to identify like a pocket, like in paracentesis. Then you can put the probe down and like you know that the pocket's good. It's kind of like that, but I'm using the probe to say like I'm going to go right above the probe and go in. So I might not see a great view of the needle tip, but I know that I'm in the right spot for these aspirations. Cool beans? All right. We talked about in the first group, I have like 100 ultrasound images that I haven't really shown anybody. And I got through 13 today. So we'll do more.
Yeah.
All right. Thanks, everybody.